Welcome. Today we review the 2023 ILA Task Force Guideline on the treatment of neonatal seizures, Pressler et al., Epilepsia 2023. This is the first comprehensive international update since the 2011 WHO/ILAE/IBE guideline. Frame for the audience. This is a clinically actionable guideline. By the end, you should be able to 1. State the first and second line ASM. 2. Know when to deviate for channelopathy and cardiac disease. 3. Know when to stop ASMs. And 4. Recognize when to trial pyridoxine. Note the methodology up front. Where randomized evidence existed, it was graded with grade. Where it didn't, recommendations came from a formal Delphi consensus of the task force. I will flag for each recommendation whether it is evidence-based or consensus-based, because that distinction matters when we apply it at the COT side. Learning objectives. Set expectations. Walk the audience through the 4 blocks. 1. The clinical problem. Seizures are the commonest neurological emergency in the newborn. Management is highly variable between units, which is exactly the gap this guideline addresses. 2. Methodology. I'll keep this brief, but it matters. It tells you how much weight to put on each recommendation. 3. The 6 priority question recommendations, the core of the talk. 4. Translation to practice, the suggested pathway, a dosing reference table, and 2 unit-level considerations, standardized pathway plus parent communication. Invite consultants to challenge how these map onto our local protocols as we go, particularly dosing, which is region and unit dependent. The clinical problem. Key teaching points. Neonatal seizures are common and time-sensitive. The dominant cause is acute provoked, symptomatic seizures, overwhelmingly HIE, then hemorrhage, stroke, and infection. A minority, 10 to 15%, represent true neonatal onset epilepsy, channelopathies, KCNQ2-3, structural malformations, or inborn errors of metabolism. These behave differently and sometimes need a different first-line drug. We'll come to that. The single most important practice point on this slide is the EEG message. Most neonatal seizures have no clinical correlate. They are electrographic-only. Relying on clinical observation alone misses the majority and misclassifies non-epileptic movements. ASMs cause electro-clinical uncoupling. The clinical signs stop, but electrographic seizures continue, so you cannot judge response clinically. Conventional video EEG, CEEG, is the gold standard. AEEG is a useful bedside adjunct, but has variable sensitivity specificity and should not be the sole detection method. Context: the last international guideline was 2011, a decade of new evidence, especially RCTs of levetiracetam versus phenobarbital, justified this update. Methodology: why you can trust the recommendations. The task force followed the ILAE handbook rigorously. A Prospero-registered systematic review reported to PRISMA 2020 standards, searching Medline, Embase, and Cochrane Central. Critical inclusion criterion: only studies with EEG-confirmed seizures were counted for efficacy. This excludes trials that treated clinical-only events, which inflate apparent efficacy. Risk of bias: Cochrane tool for RCTs, Robbins I for non-randomized studies. Grade was used to rate evidence quality, high to very low. It could only be applied to 3 questions: first-line ASM, Q1, second-line ASM, Q2, and hypothermia, Q4, because only those had RCTs or controlled data. For the remaining questions, and for nuances RCTs couldn't answer, they used a formal Delphi consensus: 5 rounds, 66% threshold for agreement. Bottom line for the audience: when I say evidence-based recommendation, that's grade-backed. When I say consensus-based, that's expert Delphi agreement in the absence of strong trials. Still useful, but you should weigh it accordingly. Also note, no pharmaceutical or device industry representation, and 218 studies were assessed against the 6 questions. 6 recommendations, the map of the talk. This is the slide to anchor the audience. Read across the 6. Point out the visual coding. The 2 mint outlined cards, 1 and 4, are the only evidence-based recommendations. first-line phenobarbital, and therapeutic hypothermia. The other 4 are consensus-based. A useful framing question for fellows: which of these 6 do you think is supported by an actual RCT? Most will be surprised that only first-line ASM and weekly hypothermia are. It underscores how thin the randomized evidence base in neonatal seizures still is. We'll now take each in turn. For consultants, the practice-changing ones relative to 2011 are A, the explicit channelopathy carve-out for first-line therapy, B, levetiracetam preference in cardiac disease, and C, the clear recommendation to stop ASMs before discharge, regardless of MRI EEG. Recommendation 1. First-line, phenobarbital, evidence-based, strength moderate. The headline: Phenobarbital remains first-line for essentially all neonatal seizures, regardless of underlying cause. This is the only recommendation backed by moderate-quality grade evidence. The pivotal data, the NeoLev-2 type comparison. In the RCT comparing phenobarbital with levetiracetam, phenobarbital achieved seizure control in about 80% versus 28% for levetiracetam, RR 0.35. That's a large, clinically meaningful difference, and is why levetiracetam, despite its friendlier side effect profile, is not recommended first line. Against phenytoin, phenobarbital showed no significant difference. The exception, high agreement, if you have a reason to suspect a channelopathy, classically a positive family history of self-limited familial neonatal epilepsy due to KCNQ2/KCNQ3, then a sodium channel blocker, phenytoin or carbamazepine, is the rational first-line choice because these babies respond preferentially to it. Important caveat for safety: in the absence of a positive family history, do not delay treatment hunting for a channelopathy. Give phenobarbital. And a specific trap: rare loss-of-function SCN1A variants can be worsened by sodium channel blockers, so if that mutation is known, avoid them. Discussion prompt for consultants: phenobarbital has real adverse effects: sedation, respiratory depression, possible neurodevelopmental signal. The guidelines answer is to use it for the shortest duration necessary, which sets up recommendation 3. Recommendation 2. Second line. Consensus-based, underlying evidence, very low quality. Reality check. The RCT evidence for second-line therapy is weak. Small numbers, add-on designs, no washout. None of the head-to-head comparisons, phenytoin, levetiracetam, midazolam, lidocaine, showed a clear winner. So this is a Delphi-driven recommendation. Default. Most etiologies, HIE, stroke, hemorrhage, use phenytoin or levetiracetam. The expert vote leaned toward phenytoin, 61%, and levetiracetam, 22%, but without consensus on a single best agent. So treat them as reasonable equivalents and let availability, drug level monitoring, and side effect profile guide you. Midazolam and lidocaine are the next options. 2 important modifiers: suspected channelopathy by clinical or EEG features, not just family history, to a sodium channel blocker, phenytoin or carbamazepine, depending on whether the baby is critically ill and on regional availability/monitoring. Cardiac disorder. Levetiracetam is preferred because phenytoin and lidocaine carry cardiac toxicity risk. Safety emphasis, bottom bar. Lidocaine must not be used in a baby who has had or is on phosphenotoin, proarrhythmic combination, nor in congenital heart disease, and always requires cardiac monitoring. This is a common exam and real-world pitfall. Recommendations 3 and 4. Rec 3. Duration. Consensus, high agreement, 87%. This is one of the most practice-relevant points for fellows. After acute provoked seizures have stopped and there is no evidence of neonatal onset epilepsy, you should discontinue the ASM before discharge, and crucially, regardless of MRI or EEG background abnormalities. 80% of experts agreed this holds even when imaging or EEG looks abnormal. This is supported by a comparative effectiveness study, published after the review, showing no difference in neurodevelopment or epilepsy at 24 months between babies whose ASMs were stopped versus continued at discharge. Practical message: don't send babies home on long-term phenobarbital just in case. It has its own risks, and the data don't support it for provoked seizures. Rec 4. Hypothermia. Evidence-based, but weak. Grade low. 95% agreement. In term neonates with HIE, therapeutic hypothermia may reduce seizure burden. Be precise about the claim. Cooling is a neuroprotective therapy that appears to lower seizure burden as a secondary effect. It was not evaluated as a primary seizure treatment, and you do not cool a baby in order to treat seizures. The evidence is observational, historical or real-time controls, hence low quality, but with very high expert agreement. Tie it together. Cool the HIE baby for neuroprotection. Treat breakthrough seizures with phenobarbital. Stop the ASM before discharge if the seizures were provoked and resolve. Recommendations 5 and 6. Rec 5. Seizure burden and outcome. Consensus, moderate agreement, 74%. The principle is that lowering total seizure burden, and this explicitly includes electrographic-only seizures, not just clinical ones, may improve neurodevelopment and reduce the risk of later epilepsy. Be honest about the evidence. Numerous studies link high seizure burden to worse outcomes, but whether actively reducing burden changes outcome is not proven by RCTs. The trials were underpowered. Still, it's the rationale for aggressive EEG-guided treatment of even subclinical seizures. This is also why the International Neonatal Consortium's 30 seconds per hour threshold for starting treatment exists, though the guideline notes that number is somewhat arbitrary. Rec 6. Pyridoxine. Consensus, high agreement, 100%, 96%. A trial of pyridoxine as an add-on should be attempted in 2 situations. 1. Clinical or EEG features suggestive of vitamin B6-dependent epilepsy, e.g. ALDH7A1/antiquintin deficiency, PNPO deficiency, and 2. Any neonate with seizures refractory to second-line ASM and no identified etiology. Practical points. Give it before genetic results are back. A therapeutic trial doesn't affect diagnostic samples. Continue 3 to 5 days before calling it a failure. Responses can be delayed. Watch for apnea/respiratory depression with the loading dose. Have ventilatory support ready. If PNPO deficiency is suspected and pyridoxine fails, try pyridoxal 5.5 phosphate, PLP, even though it's not licensed as a medicinal product. Treatment pathway, adapted from Figure 3. Walk the algorithm top to bottom. This is the slide consultants will photograph. Entry. Every step assumes EEG confirmed, or at minimum AEG confirmed, seizures. Don't start this ladder on movements you haven't confirmed. Step 1. First line. Phenobarbital 20 mg per kilogram IV. A second load of 10 to 20 mg per kilogram can follow. Have respiratory support ready for the second load. Deviate only for channelopathy by family history, phenytoin or carbamazepine. Step 2. Second line. Phenytoin or levetiracetam. Branch points. Cardiac disease, levetiracetam. Channelopathy features, sodium channel blocker. Midazolam or lidocaine as further options. Mind the lidocaine contraindications. Step 3. Refractory or no identified etiology. Trial pyridoxine and PLP if PNPO is suspected. Cross-cutting principle, bottom line of slide. Escalate based on EEG response and treat electrographic-only seizures, because clinical signs uncouple from the EEG once you give an ASM. Remind the audience that doses here are examples and must be adapted to PMA, weight, hypothermia status, and local protocols, which is the next slide. Dosing table. Table 2, quick reference. Emphasize the disclaimer first. These are suggested doses, derived from the literature and author experience. The working group approved them via Delphi, 84% agreement. They must be adjusted for postmenstrual age, weight, hypothermia, and, most importantly, your unit's own protocols. Do not read these as prescriptive. Highlights worth saying aloud. Phenobarbital, load 20 mg per kilogram, may repeat 10 to 20. If you give the second 20 mg per kilogram, have respiratory support ready. Prolonged half-life in the first week and in preterms. HIE affects renal, hepatic clearance. Consider levels on maintenance. Phenytoin, fosphenytoin, dosed in phenytoin equivalents. Target level 10 to 20 micrograms per milliliter. Levels run higher during hypothermia. Mandatory cardiac monitoring,
poor oral bioavailability. Levetiracetam, the best tolerated, but remember it's second line on efficacy grounds. Lidocaine, the tapering infusion regimen, 7 to 3.5 to 1.75 milligrams per kilogram per hour, and the hard contraindication with phenytoin and in cardiac disease. Midazolam, titrated infusion, must be tapered. Pyridoxine, apnea risk on loading, ventilatory support available. Invite the consultants to compare these against our NICU formulary so the fellows leave with the local numbers, not just the guidelines examples.
Unit-level considerations. These are considerations, not formal recommendations, but they matter operationally. 1. Standardized pathway, 100% agreement. Neonatal seizure treatment is time-critical. Studies show earlier diagnosis and treatment respond better. Every unit should have a written, agreed pathway so that the first-line drug is given fast and correctly, day or night, regardless of who is on. This is exactly the kind of QI deliverable a fellow could lead. Tie it to our own setting. Do we have one? Is it current with this 2023 guideline? 2. Parent-guardian communication, 79% agreement. Families must be told the baby is having seizures, the likely causes, and the initial treatment plan, including ASM side effects and expected duration. The caveat? This conversation must not delay treatment in an acutely unwell baby, and it's iterative as the picture evolves. The parent representative on the task force championed this point. Use this slide to pivot from what the guideline says to what we will change here, a good place to assign actions before the summary.
Take-home messages, close, and discussion. Recap the 6 in one breath. 1. EEG is non-negotiable for diagnosis. Treat what you confirm, including electrographic-only seizures. 2. Phenobarbital first-line for nearly everyone. Sodium channel blocker first only when channelopathy is likely by family history. 3. Second line is phenytoin or levetiracetam. Levetiracetam in cardiac disease. Respect lidocaine's contraindications. 4. Stop the ASM before discharge for provoked seizures, regardless of MRI EEG. Don't default to long-term phenobarbital. 5. In HIE, cooling may reduce seizure burden. Aim to lower overall burden. 6. Trial pyridoxine, then PLP, for suspected B6-dependent epilepsy or unexplained refractory seizures. Final framing. Only first-line phenobarbital is backed by moderate evidence. The rest is consensus on a thin trial base. So these are reasonable defaults, not rigid rules. And the research agenda, pharmacokinetics, dose finding, licensing RCTs, is still wide open.